Katie Breen with the Colorado Perinatal Care Quality Collaborative. Thank you all for joining today. I'd love if you could introduce yourselves in the chat and say your name, your role, and your hospital, just so we know who is here today. And I'm very excited to introduce Dr. Christina Wood, who is going to be talking to us today about pain management, which obviously is a very important topic, both for patients who we identify as having substance use disorder, but then additionally, we know that having a cesarean delivery can also be a risk factor for developing substance use disorder, depending on what kind of pain management we prescribe. So it's a really important topic and very germane to substance use disorder. And I'm very excited to have Dr. Wood here.
Thank you. Thanks for having me, you guys, and thanks for everybody who's attending. I'm seeing people kind of sign in right now. Welcome, welcome. And I've left plenty of time for questions, hopefully, so feel free to ask as many as you like at the end. I kind of wanted to start first, though. We have a little Zoom poll that I just put some random questions together about some topics I'm going to cover, and just wanted to see what people's knowledge is or experience is with some of these things. So could we load up the Zoom poll for them to complete?
Oh, that's the wrong poll, Callie.
It's only 5 questions, I promise. It's quick and painless. Perfect. So I'll just give everybody just a minute or two. Just, don't think too much on it. Go ahead and just answer whatever you think, even if you have no clue. And Kelly, can you see like just the number of people that are replying?
Yes, we can see that.
Yes.
Okay.
Right now, there's been 4 out of the 27 have participated.
Okay. Yeah. So if you're seeing the poll, please fill it out. And I know for me, I have 2 screens up, and it was actually on my second screen. So if you don't see it, maybe just look around.
Perfect. Yeah, I'll give everybody another minute, and I can even start talking and just kind of fill it out as I'm going here. But so basically, I'm an obstetric anesthesiologist. I work at both Children's Hospital and University of Colorado, and I'm an associate professor. So I do lots of teaching and love talking about pain management for cesarean delivery. So hopefully I can give you guys some good information. All right, I have nothing to disclose. Any medications or techniques that I'm mentioning are not tied to any type of company. So there is nothing that I'm getting paid for doing this. And today, really what I want to go over is just basic analgesic options for cesarean delivery in patients that maybe don't have a substance abuse or substance use disorder. And then talking about some of the pharmacologic agents you'll see your patients on as they come through that do have use disorder. And then really educating how we can manage these guys to the best of our ability for the best outcome for mom and baby. I was part of developing some of the Colorado Cure guidelines. So I thought I would just break some of that down because I know that if anybody's looked at it, it's huge and dense. And, I would make it most applicable to what we're talking about today. And then finally, I want to share the latest and greatest, and some of you may already be doing this at your facilities, but the Society for OB Anesthesia and Perinatology came out with early recovery after cesarean guidelines that I'll break down briefly at the end. All right, how many polls? I'm just curious to see what the poll is.
I can end the poll now. We have a good number.
Okay,
and then
cool. Let's see
the results.
Okay, so, oh wow, we're kind of split. All right, that's cool. I will tell you, this isn't, common knowledge. So, all right, we're kind of split across the board on the first one with acute pain can develop into chronic pain over what percentage following cesarean. So we'll talk a little bit about that. And Awesome. Okay. Most people chose the suicide and drug overdose. That probably was a giveaway given what we're talking about here today. And then, okay, a little mixed on how many guys are going to become chronic opiate users. And okay, most people picked fentanyl for what has the highest affinity. And yep, buprenorphine was the most common answer for, okay, so you guys are in this. Maybe a couple things I can share with a little more information. So as we all know, opiate use prescriptions have gone up, hugely in the past 20 years.
It's really awesome, not like.
Oh, do you guys mind muting whoever's on?
Specifically for each dog on a shift. So yeah, we gotta know beforehand.
Do you guys mind muting whoever's on? Thank you. All right. So in 2014, they just did kind of a national survey looking at people in the United States that were actually diagnosed with an opiate use disorder that was related to a prescription that they were given, and found millions of men and women. So we know this is common. I thought this was a very interesting and yet sad statistic that every 25 minutes there's a neonate born in the US with withdrawal syndrome. So something I'm sure everybody has come across or will come across. And in Colorado, you guys all got that answer right. You're right. Suicide and drug overdoses, when they came out with the latest report from the Maternal Mortality Board last year, this was the most common cause of maternal mortality. So something we need to do a much better job of. And when we look at delivery hospitals over the 15-year span listed here, we see that the opiate use disorder has quadrupled, and we are probably missing a great deal of people on that too. And then this may be a little interesting to you guys. I know people were kind of all over the board with the answers here, but the opiate naive pregnant women that come in for a cesarean, 1 in 300 are going to become chronic opiate users. So more frequent than I think we should be seeing. And the problem is, dealing with these patients is it's heterogeneous. There's a lot of reasons that people are using opiate medications or maintenance medications. And so we really have to try to tailor things specific to our patients. And due to the withdrawal stress of the fetus, that can result in preterm labor, hypoxia, demise, we absolutely do not recommend that you detox during pregnancy. If you are on a maintenance medication, we want to see you continue that. And I will say, being in the operating room, I still frequently see patients come in that have been advised to stop taking their methadone or the buprenorphine or the Suboxone that they were taking. So just a quick, getting everyone on the same page with cesarean deliveries. As we know, it's the most common major surgical procedure that we see in the United States, with well over 1 million of these happening every year. And when you ask pregnant moms, what's the most important thing with their care? Obviously, their most important outcome is a healthy baby or babies, but they really rank good pain control as their top priority for their management. And in acute pain, this can develop into chronic pain in 1 out of every 5 of our parturients that we take care of. So we really have to be on top of treating that acute pain very aggressively. Obviously, if you're in a lot of pain, you're not sleeping well, postpartum depression can be significantly increased in these populations. And then it makes a whole lot of sense that if that's how your experience is after you deliver, your good pain control is going to be better maternal neonatal bonding. Bad pain control, it's going to be really hard caring for your child. So this is what we recommend for pain control. Unfortunately, in the United States, more than 90% of our cesareans are done under Neuraxial. And for those of you that may not know, Neuraxial is a combination of either a combined spinal epidural, or an epidural. So it's medicine in your back that makes you nice and numb for the entire procedure. It's a local anesthetic that we use that stays all in your back. It's not going to baby. It's not going throughout your system. So it doesn't affect your uterus. It doesn't affect your baby, but it keeps you nice and numb for a couple of hours, which is plenty of time for the cesarean. And then that postpartum period where our nurses are doing really good fundal checks that are not comfortable, it's helpful to have this on board then too. We talk about not wanting to use opiates, but I will tell you, this is the one part that is really helpful. And these are in teeny tiny doses that we put into your back. Fentanyl is very helpful in your back. It helps with the density of the anesthetic for the cesarean. Again, little bitty doses. This also lasts for a few hours. Morphine is much more critical in my mind. It's also a very small dose. And so I just listed doses here in case anybody was interested. But that duration for the morphine average is about 24 hours. And the morphine is not going to make your legs weak. It's not going to make you numb. So you can get up and about and move around when the bupivacaine is worn off, but still have that pain control from the morphine. But it's in such a small dose, it's not, giving anybody a sensation of feeling high or any of that. So that's really important for when we get to our opiate use disorder patients. You can also consider running an epidural infusion after the cesarean to buy yourself a little more time of pain control. We don't routinely do this because, as I said here, likely you're not getting up and out of bed if we've got an epidural. Your legs could be weak. And we all know these moms are really high clot risks. We know that we need to start some of these moms on anticoagulation, and we can't always do that with an epidural in place. But we'll talk about running the infusion when we talk about our opiate use patients. So here's kind of the crux of everything, and I'm hoping that a lot of places are already using this, but here's just some data too to further support this, is using non-opiate pain medications. So I know Tylenol sounds kind of silly. It's over the counter. I hear from patients, they're like, that's not really going to help. It does. And when we do research, it has about a 20% opiate sparing effect. We recommend scheduling it every 6 hours. Don't wait for the patients to ask for it. Definitely schedule it. And then combine that, if you can, if there's no contraindications to the patients, with an NSAID. And again, that's going to have up to 50% opiate sparing effects. So if you combine the two, you're looking at like 70% opiate sparing effects by just scheduling these two over-the-counter patients. We use ketorolac, which is an IV or IM form of an NSAID for the first 24 hours and then switch to ibuprofen. But honestly, either way, you can do just ibuprofen the whole time too. And we give these for the entire duration of their hospitalization, every 6 hours. And I've had some people ask me, I go, okay, well, how do you come up with 6 hours? Why 6 hours? Because we originally, when we were developing some guidelines, we thought, well, maybe we'll alternate every 3 hours with one of them. And then we thought, well, can you imagine going in every 3 hours to give a medication, waking a mom up? It's a lot of disruption. And the data shows us that putting them together once every 6 hours gives mom a bigger break in between of getting medications, but they have synergistic effects, so it still lasts a long time for them. And this is just a graph. If you don't want to take my word for it, this is a publication. And on the y-axis, you can see it's the proportion of patients who didn't require an opioid. And on the x, it's the time to first opioid. The gray line that's lower there is just giving as needed when patients requested Percocet. So that's Tylenol and an opiate. And then if you look at the black line, that's just giving scheduled Tylenol and an NSAID. So significant difference, much less chance that they're going to use opioids. And if they do, it's going to be a lot longer before they ask for one. Gabapentin, I'm going to talk about a little bit later, but I just throw it in here because I've gotten a few questions over the last year about adding this in for cesarean deliveries routinely. And there's been some studies done on this. It's a GABA medication, so it can be sedating. It's used for pain and anxiolysis, but it's really not recommended for routine use. The doses that you would need makes moms really sedated. It does cross into breast milk. And the studies that have been done shown a pretty low number of that needed to harm is what you see down there of 12. So I wouldn't recommend this as standard of care, but it certainly has its place, and we'll talk about that. Peripheral nerve blocks are something else that I really think are useful to do. These are something that our obstetric anesthesiologists are trained to do. Certainly our pain physicians are trained to do too. So hopefully you have somebody in your facility that's able to do these. Now, what they are is, this is a complicated picture here, but what you can see is the yellow line set is showing where the transversus abdominis plane block covers. And you can see it's going to cover that lower abdomen where that Phanon steel incision is pretty nicely. So these are just a single injection kind of on either side of the hip of local anesthetics. Lasts up to 12 hours. They can be used in the case. They can be used as a rescue later that day or the next day. People have put little catheters in there and connected them to bulbs under pressure, so the medicine can be delivered for several days at a time. And, up to you, but at least it's nice to have that technique available, especially if you have patients that can't get a spinal or an epidural or can't get the neuraxial morphine for some reason, that these blocks have been shown to be just as good as that, but they don't add anything to it. So if your patient has gotten neuraxial morphine, we don't then do a tap block or a transversus abdominis block. There are some case reports of local anesthetic toxicity, so it's something that your anesthesiologist should be very mindful of how they're dosing. The second block that's newer that came out just in the last few years is called a quadratus lumborum block. And so this is on the picture, you can see a purple line all around the patient's belly, and this is a QL block. So this is where we place the local anesthetic a bit more laterally, injection on each side, same local anesthetic, usually bupivacaine, and this covers kind of the whole abdomen. So you're getting a little bit more of some visceral as well as somatic coverage for this. And this can be used as a rescue. It lasts a little bit longer, up to about 18 hours, and is something that we've definitely used for our patients as well. There's not great data that shows it provides a lot more benefit with the morphine, just like the tap blocks, but it's something to think about, and certainly something to think about in more your chronic pain and opiate use disorder patients. Again, just a little bit more proof. This is a Kaplan-Meier graph here. On the y-axis is percent of patients not requiring rescue analgesia, and then time is on the x. And you can see that the green line is QL blocks, so the quadratus lumborum blocks. The blue line are tap blocks. So the patients that got the QL blocks didn't need anesthesia more, didn't need more pain medications, or they needed it a lot later. So if you have a choice between the two, a lot of us will go for the QLs now, but either one are fine, whatever your anesthesiologists or pain docs are comfortable. Now, wound soaker catheters are something that I don't see routinely used, and I would love if they did. We have some awesome obstetricians that place these, and they tell me that they're not very complicated. It's basically this cartoon you can see off to the side over here has a little blue catheter that goes through the skin, and the catheter goes under the incision, the C-section incision, and it has a bunch of holes in it. So if you think of like a garden hose with a bunch of holes and you put water through it, it sprays it out. You can see the local anesthetic in the picture below there dripping out the local anesthetic. These are also connected to a little bulb of the local anesthetic that compresses over time. And we can have these in for 2 days or 4 days. We can keep changing the bulb as long as we need it. But these are really helpful. And what we found is they reduce pain scores, they reduce opiate use. Moms can walk around with them. They feel much more comfortable. And where we do a lot of deliveries of babies that have anomalies at our Colorado Fetal Care Center, we did a study looking at patients that got these and those that didn't, and found a 30% reduction in their opiate use. And then when we added on our NSAIDs and our Tylenol that was scheduled, we found a third of our cesareans now no longer take any opioids. So just another kind of trick and something that our obstetricians can place for that.
Dr. Wood, we have a question.
Oh, sorry, I didn't see it. Yes.
No, it's okay. I know it's hard to see when you're sharing your screen. Does it increase the risk of infection with wound soaker catheters?
That was something that's a great question. And that was something that we looked at. We have not seen that. And I think part of the reason is, one, it's placed at the time of the cesarean where everything is very stable. The wound soaker catheter is just as small as like an epidural catheter, kind of like fishing line. And so it goes in through the skin, and then your sterile dressing from your cesarean is placed on top of that. The catheter is then taped down with some tegaderms and connected to a bulb. And so we looked at two things. One, increased infection risk, and we didn't see that. And I haven't seen that in other studies. And then we also looked at, sometimes we were changing out the bulbs if we felt like patients needed more than 2 days. And we didn't see an increased infection risk with that either, but great question.
And what about poor healing with the on cue?
That's another great question. No, we haven't seen that at all. We haven't seen like serosal like hematomas or any fluid collections that are there. And part of it is it runs at 2 cc's an hour. It is not a huge fluid collection that gets under there and stays. So it gets absorbed pretty quickly. It's a small volume. So we haven't seen any wound dehiscence from that at all. And in fact, we use them in our bigger fetal surgeries that have larger fan and steel incisions, and we had the same outcomes. We were a little more worried about, you know, kind of fluid collections with those guys, but we didn't see that either. Are there other questions that you can see on there that I just can't see? Sorry.
No, there are no
Okay.
other questions in the
Cool.
chat at this time, but everyone feel free to keep chatting in your questions, or you're
Yes.
welcome to come off mute as well. And of
Yes.
course, we'll have time for discussion at the end too, but feel free to ask your questions as they arise.
I'm very informal, so please break in and ask me what you got. I love talking about this stuff. So now I was just going to move to the opiate use disorder patients. And, you know, there are definitely barriers for our pregnant ladies, not only lack of access to care, but just that social stigma too. And I'm sure, you know, I've heard it where I've been, I'm sure you have too, just kind of side comments or criticisms or thoughts about patients that are on some of these opiate medications or maintenance medications. A lot of the time, if they need treatment, it's really hard if they're trying to care for a child too. There's hardly any facilities that have childcare available. And then, you know, the criminal aspect of it, the child welfare consequences, are they going to lose their baby? These are all big concerns and real concerns that they have. And then, you know, these providers with, you know, access to obstetricians and addiction medicine specialists that really can help manage them is somewhat limited depending where you're at. And Dr. Klee is one of our fabulous addiction medicine docs that works with us all the time with our patients and is such a wealth of information. So if you have access to her or anybody else at your facility, please use them. So now I'm going to cover kind of the two most common medications that you're going to see your patients come in on, and then ways to manage and kind of treat that. So methadone is one. It's a synthetic mu opioid. So that's one of the most common receptors for opiates to target. And methadone is IV and PO. So patients can certainly take it as an outpatient, or they can receive it in the hospital. It's used for acute and chronic pain. So when I'm doing some big surgeries in the operating room, I've certainly given patients methadone to help with that pain afterward. But in this case, we're using it for moms with opiate dependence. And high bioavailability. So whatever you may be dosing in the hospital IV can convert pretty easily to PO doses. But we do know, like we're finding with a lot of our medications now, there's polymorphisms in the genetics. So the particular, you know, mechanisms and how they're metabolized will vary from person to person. So when you're starting this, you have to keep a close eye on mom and make sure that what dose you're using is working. You should see peak levels in a couple of hours. It'll last for about 12 hours, the pain relief, but then there's a chance of withdrawal, and pretty significant withdrawal with this at about 30 to 60 hours. So this is another reason why we really don't want moms stopping this. It can be sedating. You can see respiratory depression and QT prolongation. That's important for us in OB because Pitocin can cause QT prolongation. A lot of our antiemetic drugs like Zofran and Phenergan can cause that too. So we have to be mindful watching these ladies to make sure via EKGs that that's not happening while they're on methadone. Low concentrations in breast milk, it's still encouraged to breastfeed. And you just also, with pregnancy, with that volume of distribution increasing and that clearance increasing throughout pregnancy, you have to increase these doses. So they may be on once a day that changes to twice a day or more frequently as their pregnancy progresses. And buprenorphine is the next one and probably more common one that I see. And I think one that's more recommended now. Subutex is another name you'll see with it. This is a partial mu receptor agonist. So it's going to bind to the receptor super well, but it's not going to give that stimulating effect. It also binds to some other pain receptors and nociceptive receptors too. And then if you see it combined with Suboxone, or excuse me, combined with naloxone, it's called Suboxone. And I've had people ask, well, that's so strange. Why are you putting an agonist with an antagonist? And the naloxone is not active in Suboxone unless the patient crushes it. So it's really to prevent abuse from crushing and injecting it. And buprenorphine can be given just about any modality or route. So you can see PO, sub-Q, all of these are great options, and it's been shown to really help decrease opiate withdrawal and cravings. It peaks in a few hours. It's got a very long half-life, just like methadone does as well. It's not as good bioavailability orally. So if you're changing routes, you really want to consult with your addiction medicine specialist or somebody really familiar with this medication on how to do that. The withdrawal is a bit more mild because it's not a complete agonist with this, and it's definitely okay for breastfeeding for moms. So same thing as methadone, you're going to have to increase the dosing. Sometimes I've seen people on this up to 4 times a day. And if you have a patient that has a very life-threatening complication from this, definitely IV naloxone is going to reverse it. But we say only use that for extreme circumstances because you certainly could throw her into withdrawal. Same thing for the methadone. And buprenorphine is particular because it is a partial agonist that we really have to be cautious and give much more opioids if we're going to give those to kind of overcome the buprenorphine. And we're going to talk a bit more about that. But just to give you an idea, 2 milligrams, I feel like is a fairly low dose, but you can see that it is going to block about 50% of the receptors. 16 milligrams is certainly a higher dose, but I will tell you one thing I see pretty common, and that's almost 100% of the receptors are going to be taken up by the buprenorphine. So naltrexone, I'm just throwing this out here. I don't see many women on this, but there are some. This was studied. It's a receptor antagonist to help with opiate abuse as well. Its advantages is that the fetus is not seeing any opiate exposure or mu receptor stimulation with this. The disadvantages in the studies show really poor compliance. There were some teratogenic effects that were seen on the fetus. And you do have to have mom detox off of her opioids before she can get on the naltrexone. And in one Australian study, they saw some increase in pregnancy losses. So not something we see too frequently, but you might. So I threw it in here. Now, how do we decide what medication we're going to give? Well, I'm sure a lot of you have heard of the MOTHER study, but maybe not. It's the Maternal Opiate Treatment Human Experimental Research Study. So MOTHER's a lot easier to say. And this was an international study. It was double-blind, randomized control trial. Those of us that do research, this is like the holy grail of studies from that standpoint, comparing methadone and buprenorphine. They looked at a good number of parturients at various gestational ages, and they found that a portion of them, 11% that were doing methadone, withdrew from the study, but a third almost of the buprenorphine did. And usually it was dissatisfaction with, the medication. So that was unfortunate. But the buprenorphine people that did complete the study showed that their neonates required a lot less morphine for withdrawal and much shorter hospital stays. So definitely some positive data that has then been confirmed by future studies. So a few more randomized control trials and observational studies with thousands of parturients have shown the same thing. So really the recommendation is for the buprenorphine versus methadone, better neonatal outcomes, less preterm birth, higher birth weights. However, you do have to be mindful that both of these medications put that neonate at risk for some form of withdrawal. So if you're caring for those babies, it's important to remember. All right, so how do we manage these guys? Because these can be the most challenging patients to manage that come across, the operating room for us in postpartum. Unfortunately, most randomized control trials not only exclude pregnant women, but especially those pregnant women with chronic pain and opiate use disorders. So our data is limited. So if anybody is interested in doing some research on these guys, we need it. Multimodal pain management, you're going to hear that probably 1,001 times during this talk, is the key. Really trying to target pain from all different options. Making sure that you're planning ahead. I cannot emphasize this enough. It makes such a difference if you're involving us as an obstetric anesthesiologist, our addiction medicine colleagues, involved in the conversation during the antenatal period. So we can talk with the patient about what she's taking, how to continue taking that, how we're going to help her manage that, and to let her know that we do have ways to help control her pain, because that's a big fear for these guys. Intrapartum, multimodal pain management, again, just a lot of different medications. I'll show you some more options here in a second. And if you can do a spinal or an epidural or encourage those guys along those lines, they do much, much better versus just trying to supplement them with IV or oral opioids. And postpartum, I think this is critical and sometimes gets lost, is you really want to have that plan for that stay that she has in the hospital after her cesarean. So 48 hours, 72 hours, and then really make sure she's got some close follow-up. She's connected with the addiction medicine physician. She's connected very strongly with her obstetrician. So she's got good follow-up, or her midwife, for these patients. So neuraxial, there's been some studies that were concerned about giving opioids to these patients on buprenorphine or methadone, because they were worried that if we put opiates in the spinal like morphine, they're not going to work, because part of that, is part of that medication is binding up those sites. That's absolutely not true. Please encourage your anesthesia team, if there's any doubt, to provide this for them. And really, you just need to double the dose, and then you can overcome a lot of that receptor binding. So morphine, Dilaudid, whatever they want to put in the spinal or epidural is fine. Morphine's kind of our gold standard, but you just got to increase it. And then you can redose it if her epidural catheter stays in every day. You may still need to increase the dose just in general of any other opiate medications, the oxycodone she's getting, because the studies have shown us that they have up to a 70% increased requirement. So versus patients that don't take opioids or aren't on these maintenance therapies. So you really want to be sure that you're calculating that and not just seeing your patient as drug seeking because they need more. So this is a real, phenomenon for them. Adjuvants that I think are awesome are things like clonidine, dexmedetomidine. These are both alpha agonists, so they target a totally different system than our opiates do, than buprenorphine does, than methadone does, and they provide a lot of great pain relief. So in patients, I've worked with Dr. Klee where we had a laboring patient. Normally we put fentanyl in our epidurals with our bupivacaine for labor. But there's some great data showing that clonidine worked just as, in fact, better than the fentanyl because it's targeting a different system. So these can be used as adjuvants in the spinal and the epidural, or honestly, clonidine can be given as a pill. So these are things to consider. And these are the guys that you're going to want to balance your risk benefit about being able to get out of bed and walk around and have that, thromboprophylaxis versus running the epidural for good pain control. You can run a very low dose epidural. And I don't know if at your facilities, if you have this, but we do walking epidurals. So you can titrate the concentration to where the legs aren't weak. They can still get out of bed, but they're getting some pain relief. All right. And as I said before, I get a lot of people that say, oh, well, Tylenol and NSAIDs aren't going to work for these patients. They're so ramped up on, what meds they're taking. Absolutely not true. Again, totally different system that these guys are working through. So please continue to schedule these for these guys. Every 6 hours is what we recommend. Don't let them ask for it. And some of our pain patients that have opiate use disorder feel the same way and feel that, Tylenol's not going to touch me, ibuprofen's not going to touch me. And this is where that antenatal counseling can be so helpful to get them prepared for this. This is where I would use gabapentin. So gabapentin is that GABA agonist. It's great for anxiolysis. It is a bit sedating, but is a fabulous pain medication. And you can give this every 8 hours. You can give up to pretty big doses for these moms. You just really want to make sure you're monitoring baby, because if she is using breast milk, it does get into the breast milk. We don't want to sedate baby too much, but this can be an awesome adjunct. This is a medication she could even go home on as a transition too for pain management. Dexmedetomidine or Precedex and ketamine are both, again, fabulous infusions. Dexmedetomidine is alpha agonist, ketamine is an NMDA, and I'm just telling you all this not because I expect you to know or remember all of it, but they're just totally different from opiate receptors, so they don't even target the same system. The downside for the infusions are you need to have adequate nursing staff that's comfortable with these infusions and some of the complications that can happen, either sedation or hemodynamic changes. And so you do need that really good nursing care for these, but these are fabulous infusions to run postpartum if the patients need that as well. And then lidocaine patches, again, sounds kind of silly, but lidocaine patches, they can put multiple ones on around the incision, wherever their pain is, and they can go home with these as well. So these are all things that we should be considering for our opiate use disorder patients to really help them that are completely non-narcotic. Now, if you do need to resort to, which is fine, either IV or oral opiates, that's perfectly appropriate. Again, just know that you're going to need to do higher doses than you normally would. This is a study that looked at patients both on buprenorphine and methadone and found that these were the doses that they were receiving on a daily basis in order to control their pain. So again, just to give you an idea, they may not necessarily be pain seeking or drug seeking, although you'll have to watch out for that. They're just going to require a lot more, which is why the non-opiate medications are really nice to work in. Okay, I promise I'm not going to get really deep in this, but just to give you guys an idea, you have to think about when you're working with patients that are on these medications, how those medicines are working. So you can see buprenorphine is bolded here, and this is for an affinity of how well it binds to that opiate receptor. The lower the number, the better it binds and more tightly it binds. So buprenorphine really binds well. The only narcotic that's going to bind a bit better is sufentanil. So that's a useful medication. It's something in anesthesia we use quite routinely and are familiar with. But on the other side, hydromorphone or Dilaudid would be a wonderful one to use too, because it doesn't bind quite as well, but it's pretty close. Fentanyl is a little less, so that's where you're going to really need to go up on your dose of fentanyl. And then when you get down into morphine and oxycodone, you can see how much weaker those are. So you can understand if you're giving somebody oxycodone and they're on buprenorphine, why that may not be working super well at your standard doses. You really got to go higher with those. All right, peripheral nerve blocks. There's nothing new in this than versus the patients that are not using maintenance therapy or opiates. But please do it. I can't give you any randomized control trials because there just aren't any that I'm aware of in opiate use disorder patients. But it's local anesthetic, it's non-narcotic. These are fabulous to supplement cesareans with. I've had women that have gotten, a spinal for their C-section, gotten their morphine in their spinal. The next day, they're really struggling. We go in and place these little blocks. They're comfortable for the rest of the day, can get up, go see their baby, do what they need to do. So they're very, very, very helpful. Okay, I'm going to just switch gears for kind of the last portion here and talk to you guys about some of the Colorado's cure guidelines. And a lot of this started looking at opiates and responses to things outside of obstetrics with cancer. And they were finding that opiates can really impair some of that immune response. So that field really has started blowing up as well, trying to find non-opiate treatments too. And so we thought this would be a great way to kind of segue into the OB and pregnancy and cesarean deliveries. So opiate-related adverse drug events are kind of a big deal, and they happen. They contribute to a significant longer hospital stay, higher cost of care, increased readmission risk, as well as a risk of mortality. So it's not benign. In addition, they can predispose to long-term opiate use, as a lot of you are aware. So these guidelines are dense. I'm just going to kind of break these down a little bit as far as they apply to cesarean deliveries. And again, you can see our friend multimodal analgesia. This is really what they encourage, just everything we've been talking about for the past half an hour or so. And the preference is for non-opiate medications and use the opiates for breakthrough. But try to get those other guys on board. Use regional whenever possible, including peripheral nerve blocks, including wound catheters. So all of that is super helpful. And these guidelines are just what I've been telling you earlier. I think this is something that we forget to do a lot. Or I can speak to myself, I have to remind myself, is really talking to the patients about their expectations. If they live at a chronic pain level of 7, you're not going to take that down to 0 after their section or 5. So you have to have really realistic expectations with the patient. What's reasonable for them, where they're going to be at 24 hours versus 48 hours versus 72 hours. And when you have that game plan going in, it's much easier for that patient to cope and manage. Enhanced recovery pathways. And I'm just wondering, maybe I can see it in the chat here. How many people are using these right now? Anybody? For C-sections, enhanced recovery pathways? Okay, I'm getting silent. So if not, that's good.
Sure,
'cause
we use them.
I,
You guys do?
this is Lisa Becker. I work at PSL. Health One has put that into the standard order set for all postoperative patients, including the OB patients.
Oh, that's fantastic.
Yeah, all of SCL has as well.
Perfect. Okay. Well, I'm just going to review it very briefly at the end, what our kind of governing body, the Society of OB Anesthesia, came out with this year, of just kind of a pre-op, intra-op, post-op things that we think about. So hopefully it's stuff you guys are already doing, and will just be a little bit of a reminder then, but definitely use those. And then anxiolysis is really important. And when I say that, people usually think I'm talking about giving them some Versed or some Ativan. And that's helpful. And you certainly can consider that. And if that's what patients need, by all means. But we found real success in things that are a little different than that. Having patients play music, bring their own playlists into the operating room. It's a nice distraction for them while they're laying there and we're prepping their belly and there's a lot going on and they're staring at a blank ceiling. So we found that's been really relaxing. Aromatherapy. If patients have a scent, lavender, eucalyptus, or something that works really well for them, I have them put it on a little cotton ball or a piece of cloth and they can bring it into the OR. It makes them feel a lot better just kind of smelling something that's comforting to them. And then desensitization therapy. We're doing a multi-center study on it right now, but there's some good data showing that if you can get that patient before they deliver, kind of a formal walkthrough of the operating room, a formal walkthrough of what's going to happen with that cesarean, as well as talking about what pain meds they're on, how you're going to manage that, how things are going to be taken care of. We found a significant reduction, not only in opiate use, but just their anxiety and trauma experience from all of this too. So think outside the box with some of these things. And then communicate. 100% everything, as we all know, is about communication with all the team members. Importantly for orders, that things aren't getting ordered by anesthesia and OB and midwives, and that we're double doing things and that we're all on the same page. And one thing that I think gets left out a lot is ask them about the marijuana use. In Colorado, people think because it's legal, it's okay, it's safe, it's no big deal. I will tell you as an anesthesiologist, these guys are really tough to manage for pain, really tough to manage for nausea. So it's good going in knowing that they're taking this and how much they're taking. Consider that they may need to be on something like gabapentin, afterwards. So what kind of prescriptions are you going to need to give them for when they're going home? And please don't deny anybody, pain relief. Again, I know these can be tough patients, but pain is pain. And we want to make sure we're really treating that. And who's going to help you is consulting your services, your acute pain services, your addiction medicine services. They are super valuable for that. So I'm just going to finish up in a couple of minutes here. So there'll be lots of time for questions if anybody has any with what these guidelines are. So the Society of OB Anesthesia and Perinatology, like I said, is our governing body, and these were published recently. And they just broke them down into kind of pre-op, intra-op, and post-op recommendations. These aren't all opiate recommendations, but just kind of in general ways to really enhance that and improve that experience. So as I'm sure a lot of you do now, we don't say your NPO after midnight. We say no solids for 8 hours, not 12 or 14 hours, and drink clears pretty much until you get up to the hospital. A lot of our moms arrive 2 hours before their cesarean. So drink that apple juice, that Gatorade, as long as you can see through it, do it. It's going to make you feel better, help with that gut motility, and really providing that education. Breastfeeding, especially when they're on opiate medications or other maintenance medications, really important to advise them on what's going to be best for that baby. And like I said, what to expect with surgery is huge. Optimizing that hemoglobin, that oxygen carrying capacity is going to be really good for that wound healing, just all that tissue perfusion, improving that outcome after the cesarean. Things in anesthesia that we can do is maintain baseline blood pressure. It's no longer recommended that we maintain blood pressure within 10% of baseline or 20% of baseline. Really, we have to maintain with what her normal blood pressure is, right where it's at, even after a spinal, even after an epidural. And these are just some pressors that we use. They're all fine for pregnancy, all fine for the neonate or the fetus as well. Normothermia. I know it can get hot in that OR. I know, especially if you're in a gown and under those lights and you're doing surgery and you're sweating, it's really hard. But we really want to try to maintain that normothermia for mom, because when we do a spinal for her, we're dilating all those blood vessels from her chest down. So her ability to maintain heat is lost with a big portion of her body. So we really want to do whatever warming techniques we can. And then again, our famous multimodal analgesia. I think I've beaten that dead horse enough for you guys. Excessive use of uterotonic medications. Obviously, give what you need, but avoiding some of the excessive doses of oxytocin. A lot of these can cause nausea and vomiting. And so we want to make sure we're not complicating, that wound, how they're recovering by those effects. And then antibiotics, I think everybody's giving them prior to incision now. But intraoperative, we really ask our obstetricians to avoid externalizing the uterus. There's lots of data now showing that really increases that nausea and vomiting for the patient. And there is some data showing that the pain management can be a bit more with that. Same thing with the abdominal irrigation and just making sure they're getting good antiemetics. So we always give them at least 2. Skin to skin, if you can, if baby's doing okay, if mom's doing okay, certainly you want to make sure patients are doing okay first. But if you can do that maternal bonding, that stimulation is going to help baby, but it's also going to help that mom coping with being in the OR there. And then fluids. We really want to try to limit those fluids to less than 3 liters in a non-preeclamptic patient. And because our preeclamptic's third space, everything less than 2 liters for those guys. The bowel edema is a lot less. The incision healing is going to be a lot better for that. And then I'm sure you guys are all aware about the delayed cord clamping, both for term and preterm babies. There's multiple benefits for those guys. Once you get them out of the OR, this has been, I feel like, one of the more challenging parts of one. I'd be interested to see what your experience has been with implementing ERAS, but is early PO intake. So getting them almost to a full diet within a few hours after surgery, if they're tolerating that. Getting them out of bed, ideally within a few hours after that surgery, but certainly within that first 8 hours. And they should be walking several times that first day. This is going to help with their gut function. This is going to help with their recovery. Optimizing rest, like I said, trying to schedule meds together, schedule vital signs together, so you're not interrupting that mom 1,000 times while she's trying to get rest, and removing that urinary catheter within that 6 to 12 hours afterwards too. Robust lactation support, that golden hour, I'm sure everybody's aware of. If she wants to breastfeed, either pumping or having her newborn latching on, normal glycemia. And I'd be curious to know if anybody's using chewing gum, because we started doing that this year, where we just bought some, mint chewing gum, and everybody that goes to the PACU gets that. And the data shows it really helps with that nausea and vomiting and that bowel motility and gut function return. And then ambulating, minimizing opioids, all of that kind of stuff. Okay, lots of information. These are just, I always hate when people are throwing about 50 references at you. So I would say that the coordinators here, Katie or Callie, can send these out if you're interested. But if you're going to look anywhere for this information and further data, these would be 3 I definitely would reference and take a peek at. And I am happy to take any questions at this point in time. I was going to offer the Zoom again, but you guys did really well on the first one. So honestly, I'd love to just spend the last 10 minutes seeing what questions people had. Oh, I see some people are using gum. Valley View. Is Banner using that, or was that answering another question? Who's at Banner? Oh, PSL. Okay, cool.
Hi, thank you so much. This was a wonderful talk. On our high-risk OB service, we actually see more patients who come in acutely intoxicated with methamphetamines than anything else. Do you have any specific recommendations for management for them, since it's not an opioid substance use disorder per se, but they're struggling?
Yeah, they're really struggling. I think what I found really successful with those guys is honestly dexmedetomidine works so well for heart rate and blood pressure control, because a lot of the times those guys are just so ramped up and off the charts that it's scary. I don't know what some of the blood pressures you've seen, but they're in the 200s or so, when they've come in. And so I would say dexmedetomidine has been fabulous for just kind of bringing them down off the walls, as well as hemodynamically kind of steadying things out so they're not going to have a stroke and whatnot. Obviously benzos are helpful too. I like Precedex or dexmedetomidine because it's just a little more titratable. You can do it in little boluses or as an infusion, but I found that to be a very helpful adjuvant. And I've run it in the OR, and I know this isn't part of the talk, but there's lots of data now showing that dexmedetomidine actually may stimulate some uterine contractions. So people are needing less Pitocin for a C-section too. But that's what I found is helpful for those guys.
Interesting. Thank you so much.
Yeah. Anything else? I'm happy to answer any questions about anything.
Okay,
I mean, I
now,
always have to answer.
this isn't really related to pain management, but while we
Sure.
have you on the phone and talking about ERAS,
Yes.
we are struggling a little bit with when to remove our Foley catheters for patients with Duramorph.
Mhm.
In terms of urinary retention related to that, we're just
Yeah.
struggling to find anything in the literature.
Yeah, so well, it definitely can. So morphine can cause urinary retention for sure. We know that's the truth. And that's where and I'm not sure how you guys are dosing it, but we used to give about, like, for a spinal 250 mics and call that good. We now know that is super overkill and is doing nothing but worsening urinary retention and causing nausea and vomiting and itching. So what we do is we dose our Duramorph a lot less, right around 100, 125 mics, so maybe about half that dose. And we found a lot less of the urinary retention, much easier to get that catheter out. Do you know how you guys are dosing it?
I think we might be at 250.
Yeah, so that would be my recommendation, and I'm happy. I'm sure these guys can send you my email to send you some literature about the dose response curves with that you really just don't need to be going that high. Now, if you've got your opiate use disorder patients, that's kind of another ball game. But in general, it's just, we now know that's just too much. We don't need that much. In fact, some of my friends at Stanford are doing, I think they're down to 75. mics now. We haven't gotten that brave yet, but
Okay, perfect.
yes, I would just
I
check
am
that, and I'm happy to
I'm
send
gonna
you.
actually email you and include our head of anesthesia who you know.
Perfect. I would love that. Yeah.
Okay, perfect.
Anything else?
Do you prefer the CSC versus the neuroaxial epidural?
Yeah, so I love talking about this. So I would say I like CSCs a lot, and here's why: is when you do an epidural, epidurals are great, love them, but it's kind of a blind technique. We can't tell, are we right in the middle? Are we in the perfect space? So a combined spinal epidural allows you to confirm not only are you in the epidural space because you've confirmed that you have CSF right on the other side of that, but you're in the middle. You can't get CSF if you're off to the left or off to the right. So when you look at the literature, labor epidurals by and large are, adjusted or replaced about 10 to 12% of the time. We can cut that in half or less with a combined spinal epidural because you've really confirmed where you're at. And then there's other data showing just that sacral coverage, those sacral nerves, it tends to do a bit better job covering those as well. There is not an increased incidence of post-dural puncture headaches in those patients, which is always a big question I've gotten. So.
You find there's maternal hypotension with the CSC?
No, we don't see that there is, and again, it depends how you dose that CSE. It depends what you put in that spinal dose. So if you're going to give, 3 or 4 milligrams of bupivacaine, yeah, you're probably going to see a blood pressure drop. We don't ever give more than maybe about 2 milligrams through there. And that's if a patient is really close to complete. Typically we're giving, maybe just a little bit of fentanyl, like 10 or 15 mics of fentanyl, or we're giving like a milligram of bupivacaine, and we're really not seeing that hypotension. And it's part of the reason too that we don't recommend, and I don't know how you guys are practicing, but we ask that our nurses please don't bolus our patients with fluids before the epidural. There's data that's been out for about 20 years now showing that it's not going to change hypotension. It's not going to change fetal bradycardia. If mom needs anything extra, to help her blood pressure, she's going to need that whether you bolus her or not. And if you give her a liter bolus, the first thing that's going to do in labor, at least, is slow down that labor. Now, if you want to bolus her before she comes to the OR, okay, we're okay with that. But does that answer your question, kind of?
So you're saying the amount of bupivacaine that you give is 2 milligrams and between 10 and 15 mics.
Yeah, we give it we do bupivacaine instead of rope. It's cheaper at our institution, but we do up to 2 milligrams of the bupivacaine. We don't ever give more than that for labor. You're talking about labor epidurals, right?
Yes. Correct.
Okay. Yeah. So we don't give higher than that. And maybe on occasion I've had to give a little bit of phenylephrine, after I've placed it, but not very often. And when you're dosing an epidural, if you just put an epidural in, you're having to give a pretty big bolus after you place it to get her comfortable. You can give a whole lot less in that little spinal space for a CSE. We got, I see 1 minute left. Anything else?
This was so great. Thank you for joining us.
Oh my gosh, my pleasure. Like I said, I love talking about this. So anytime I'm happy to. So thank you.
I've learned a ton. I have to thank you so much.
Oh, cool. I'm glad to hear that. Oh, you're welcome.
And we'll definitely share the slides and Dr. Wood's contact information in the follow-up email, so look out for that.
Cool. Okay, well, thank you guys.
Yes, thank you so much, Dr. Wood.
You are so welcome.
Yeah. Oh, I was gonna say, Callie, if you could launch the evaluation poll, that would be awesome. So for folks on the call, if you're a member of a hospital team, please stay on. If you're not a member of a hospital team or the expert faculty group, you're welcome to jump off, but we do ask that everyone complete the evaluation poll before you leave. And then we'll also keep chatting. So, today we're actually going to have our graduate intern, Elena, lead our discussion. So we're excited for that and to hear more from all of the participating hospital teams. Bye, Dr. Wood. Thank you so much.
Thanks, guys. Have a great day.
You too. Thank you for filling out that poll. The reason we asked to do it now is because we know there are actually some people on the call that are providers who don't necessarily participate in the learning collaborative. So that's why we wanted to do the evaluation poll now instead of at the very end. So thank you for your patience with that. And it's really helpful to get that feedback. So thanks for filling out that poll. We'll give it a few more seconds and then we can start our last 30-minute section of discussion, and we'll have Elena take it over.
Hi, everyone. I'm Elena. I am a graduate student intern with CPCQC for this year. I'm getting my dual master's in social work and public health. And I've been working on this project predominantly. But I just wanted to talk to you all and kind of start a discussion since we're pretty far into the learning collaborative and you all have been doing such great work. I've been looking at all your run charts, and especially this last month, we've seen a significant uptick and positive trend in your data. So I wanted to have a positive discussion and talk about what all your hospital teams, like what are your proudest accomplishments, or what have you found most valuable in the learning collaborative so far? If anyone just wants to share, we can have just an open discussion about it, and hopefully we can share some positive ideas that we've had so that hospitals who maybe are struggling more can see the things that are doing well and really share our accomplishments and positive impacts we've made so far. Maybe we can have one of the SCL teams start. I know you guys have all been doing really great, and we've seen a huge jump in your data this past month.
And I'll put the question prompt in the chat.
Great, thank you, Katie.
Sure, this is Amy. I think we're doing some great work on getting the last of 8 sites up and running with our EPDS screening. It's exciting. We're working on a policy, which we're nearing completion. We've picked our tool for screening for substance use. Our barriers are, we've got some turnover that were addressed that we're, I think everybody struggles with that, but some key players are leaving the team. And then I just found out that our social determinants of health EPIC upgrade is getting bumped to an undetermined date. And that's where our screening tool is going to live.
Yeah, I think, Amy, you bring up a good point about how you all are working in a pretty large hospital system. And I think that sometimes your progress can sometimes be held back by it being such a large system. So it'd be interesting to hear from maybe a smaller hospital in comparison to see how your implementation of the screening tools into your electronic medical records has been in comparison. Does anyone want to share from one of the smaller hospitals?
This is Mick at Valley View, and we were able to get our EPBS put right into our EMR so that we give them paper and then our nurses put it in. But we've had that going. Menina actually started that long ago, so it's kind of well oiled for that piece. Now we have another nurse resident starting our screening on admission for drugs and alcohol, and we're going to build that in. And I haven't met with IT yet, but that's coming this very soon. So I have a feeling it won't be too hard, but we're very blessed being that small. I think that we are able to get things done a lot more quickly than the bigger system.
Yeah, definitely. Thank you for sharing that, Mick. How are other hospitals doing with implementing their screening tools? And is there anything people want to particularly shout out that they're proud of, or that they've found rewarding about this process so far?
This is Lisa Becker. I work at PSL in the Health Fund system, and with the big hospital system, I totally agree with the person who is struggling a little bit with turnover right now with the nurses and other staff. That is a major issue. The good news is they're all very enthusiastic once broached with the information, and I think that has been the most encouraging thing for me. I think in private practice, a lot of practitioners are a little apprehensive about approaching patients with questions about substance use disorder because can be an uncomfortable subject, and there has been so much stigma attached to it in the past. What has been very encouraging to me is bringing information from this collaborative to providers. I have had some very positive feedback, people who want to help, people who will use the information. And we had 9 people from different hospitals participate in an MAT training session, which I thought was huge. I think that, gives patients a lot of options to continue treatment, even outside an inpatient setting. So I'm very happy about that.
That's great. That's great to hear, Lisa. Has anyone else held similar MAT sessions like that, or been partnering with those outpatient resources at all? I know a couple teams have started implementing their resource brochures, or been starting to spread their resource databases. Does anyone want to share about their success with that? I'd really love to hear about that.
I know some of you have made some great handouts and sheets and stuff. So if any of you that are here who have done that, if any of you who have done that aren't here, speak up.
Yeah,
I put up a bulletin board this week in the hall so that
that's
patients
awesome.
have, and it's some sort of, it's visible, but it's not in a high traffic area. So if somebody needs to take a picture of stuff as a mother information on their phone, they can. And I keep saying that I will get my handouts to the generalists, and I promise I will. We've had some very crazy shifts, but that I hope will be going out in the next week or 2.
Yeah, even those small tests of change are great. Like, I know that it's these little things that keep progressing, and that's really helped you keep moving on. And I really like that in some ways you did put it in a low traffic area so that people do have that privacy. I think that's really important. Do we have anyone from the Denver area other than SCL Health, maybe Swedish or university, that might want to share about their successes?
Oh, I don't know if Mary Gambato is on the line, but a huge kudos to her. She is at Swedish Medical Center, and she was actually on television with one of the ER docs talking about their naloxone project in the ER. So yay, Mary.
That's awesome. And we know, I'm pretty sure university, if any of you are here, I think university also might be joining the Colorado Naloxone Project.
Yeah, university is, we actually worked with our ED coordinator, and the naloxone corridor project is actually going to be system wide for our hospitals across the system, which was a big, so way more than we expected when we just tried to get it on our OB floor.
That's great. Are people familiar with the Colorado Naloxone Project? Yes, no.
And this is Amy at Lutheran. I just wanted to ask you, the site that's implementing, was that university?
Yeah, I believe so.
Yeah, we're at
Okay.
university.
So our ED is implementing the program, but they said that the funding is a little bit different if we want to be included. Do you know anything about that? They were hesitant to include us in that project.
I don't know exactly. We're still working at all the pieces. Our ED, we have a social worker who's the director of care coordination in our ED. She actually is the one that took the project and has run with it. So you could certainly email us and we can try and like connect you so we could kind of know how that works. But we just sort of kind of told that that's our next step. And so we're still working out how it looks on it always has to kind of go through our pharmacy, but we're trying to figure out how it works on our floor right now.
Okay.
And Amy, I will put this in the chat also, but so the two main people who are running the Colorado Naloxone Project overall are Dr. Don Stater, who's out of Swedish ED, and then Ryan Sipsis, who works with him on the project. And I might email Ryan if I were you to figure out that funding issue, because we haven't heard that before. And I think a lot of the hospitals participating through the Colorado Naloxone Project are getting grants, like the Colorado Naloxone Project has a grant to give free naloxone to the hospitals. So I would check with Ryan.
It has to be distributed through the ER, is what we're being told. And if it's going to be distributed through the units, that is outside the scope of the grant. And then it has to have like an individual provider order. It can't just be kept on the unit.
Can I talk? This is Cindy Middleton at Swedish.
Please.
Yeah.
So we did institute that, and we've actually dispensed our first without a hitch last week. But we talked with the ER and worked with Don Stater on this, and we were able to get it in our own Pyxis on L&D, and any OB provider can then order it and dispense it from L&D now, or postpartum.
Yeah, Amy, I would definitely talk to Dr. Stater or Ryan, because they would definitely be helpful in figuring this out, and they're very approachable. So I would definitely talk to them. And I do know that Dr. Stater really wants to move it into the L&D units. So I'm sure he would be helpful in getting that figured out for you in the SEL hospitals.
Okay, great. Thank you.
Amy, I will send an intro email right now to you and Ryan.
Oh, that'd be awesome.
Going back to people's resources and work with the outpatient or outpatient settings, has anyone else had success other than Dr. Becker? Samantha or Amber, do you want to talk about your successes? I believe you're at Good Samaritan. Well, if no one else has anything to share, it's been really great to hear about everyone's experience so far. It's really great to hear it from our perspective too, because we can see your data tracking up, but hearing these anecdotal evidence is really, it's uplifting to hear and hear your stories from on the ground. So thank you for sharing that. I really appreciate that. Does anyone have any questions about how the collaborative is going, or anything that you've been working on that you might need support from CPCQC? Well, it looks like Samantha can't get off mute. It looks like at Good Samaritan, they have similar successes to how Amy does at Lutheran and SEL, but they don't have a very high substance use disorder population. So they're just working closely on that. That's really great to hear, Samantha.
And also, I just want to add, when it comes to SUD, you know, I think Dr. Becker brought up earlier that they really see meth more often. And we hear that a lot. That's actually why this is a substance use disorder learning collaborative, even though it's the opioid use disorder AIM bundle, is because we recognize that there are many other substances at play, meth being one that's really frequent. So if there's ever anything we're talking about where you're like, well, I want to talk about methamphetamines instead, I don't see this with opioids as much, please chime in. We want to make sure we're covering all the substances that are actually relevant to you. So anytime you have questions about anything other than opioids, which I know get a lot of attention, and marijuana gets a lot of attention too, please let us know so we can make sure we're giving you the best information and support possible. Well, if there's nothing else to talk about today, we'll let you go early. I will be sending out an email with the slides that Dr. Christina Wood presented today and a recording of this call so that any colleagues who weren't able to join could watch it. In terms of things that are coming up, and of course, I always have the checklist in the newsletter, but CPCQC's annual conference is next Friday. If anyone would like to join for all or part of the day, it's a long day on Zoom, but no one has to attend every single session. And the follow-up email will include an agenda, so you can see if there are any sessions that speak to you. And then thank you all so much for submitting your August data and your midpoint surveys. It's been so awesome to see the progress, both from the month-to-month data that we see in the run charts from the cohort, but also seeing your midpoint surveys has been great because so many of you have made so much progress since baseline, and I think it's nice to have another way to look at that. So thank you for filling that out. Of course, September data will be due September 30th. So it feels like this month is flying by, but that'll happen. And then I'll also include in the newsletter registration information for the 2 events we have in October, which are our October monthly coaching call, which is October 21st, Thursday at 1, as always. And then our final learning session of the year is on Tuesday, October 26th. It'll be a half day in the morning again. We're planning some great content and workshops and participatory things for that too. So thank you all so much.
And just one more thing to add, Katie.
Yeah.
Jamie just wanted to remind people that for the conference, there is nursing continuing ed available. And then also if people can submit the survey, I sent it out, I want to say about a week ago, about just checking on their data and making sure, just want to make sure that when people started the collaborative and started submitting data that it was using a validated screening tool. So if you could just submit that, that would just be super helpful to making sure all our data is correct. But thank you all for joining today.